I'll try to be on time. My topic of today is non-surgical management of thyroid nodules, and I won't waste much time with introduction. I think every speaker has introduced nodules, and we all know that besides palpation, if we do sonography, then there is a lot more incidental detection than what we otherwise would have thought of, ranging to the extent of 20 to 76%. Again, respected Dr. Chandralula sir explained thyroids in detail, so no need to go into that. But now we have this objective criterion where we can just grade each measure what we see on ultrasound, each parameter, and give a composite score to it, and even based on size, plan the intervention or the follow-up. So coming to treatments for thyroid nodules. So especially let's take it in two parts. Let's look at benign nodules first, because there is an established and guideline based role which I'm going to talk about more, and then we'll come to malignant nodules where there is an ancillary role. So when we talk about treatment of benign nodules, as we all know, most of the nodules do not require treatment because most of them would be asymptomatic. In fact, most of them would be detected incidentally. But yes, if they are symptomatic, then the most common surgery treatment offered is hemithyroidectomy. Although benign, but that is the thing we have to do for most of the patients, especially when there are pressure symptoms or cosmetic symptoms, uh, and sometimes thyrotoxic focal nodules. There are, of course, other therapies like suppression of TSH, radioactive iodine. Previous expert speakers have talked about them, so I won't go into them. This is where or as an interventional radiologist, my role comes into picture, where for cystic nodules, we can use chemical ablation, and for solid nodules, we can use thermal ablation, which can compose of radio frequency waves, laser, or microwave ablation. So I will be talking about the subject where I have an experience on. So let's start with that. So, what is the clinical problem of thyroid nodules? As an introduction, we all know they have a malignant potential, even if they are benign at a point. There is a certain growth rate and a malignant conversion yearly. And then, of course, even if it's benign, there are cosmetic issues, pressure symptoms, thyrotoxic nodules. Traditional treatment, most common one that was being used was hemithyroidectomy, even for benign nodules, because probably there were no other options. With all due respects to surgery, of course, nowadays with the scars going minimally invasive, endocrine surgeons doing it in such expert ways, complication risk going down. Still, there are few issues that are there, a few limitations or complications occurred because of the surgery. And we all are aware of these complications, scars. Although we try to mix it with the skin crease, they do. Some people do get hypertrophic scars. There's voice change, hypothyroidism, pain, long recovery time, and so on. So when everyone, as sir mentioned, Dr. Chandi sir, that every patient is apprehensive and wants to know if there is any alternative to surgery, any minimally invasive option. So when the entire world started searching for such options, Korea was the one, especially South Korea, who led it and found out this option of uh, thermal ablation, especially for solid nodules. Treating cystic nodules was there from a long time, but for solid nodules, we did not have any alternative. So let's look at that. So Korea came out with the first research about a decade back, and this is their paper on their experience in 2015, where they compared surgery versus RFA, radio frequency ablation, which generates heat and destroys the nodule. And they compared them for multiple parameters. They took 200 patients in each arm in this study, and then what they found was that the efficacy was almost the same. Even after radiofrequency ablation at 12-month follow-up, the nodule volume had decreased from 6 ml to 0.4 ml. The incidence of complications, however, reduced from 6% post-surgery to 1% post-RFA. So they had lesser number of complications. Hypothyroidism was found almost in 72% of patients who underwent surgery, but not a single patient who underwent RFA from the 200 patients. And otherwise, the hospitalization days were less. A surgery patient had to stay for 6 days, whereas a RFA patient was there only for a day and a half or 2 days. So multiple benefits. Of course, one additional benefit of RFA is we can also target the nodules in the opposite lobe, and that helps. Whereas hemithyroidectomy, probably we are limited in that sense. So their conclusion from this study was that surgical resection and RFA are equally effective in management of benign nodules or nodular goiter, whereas RFA has few other advantages, that is fewer complications, the complete preservation of the thyroid function in all patients, and fewer hospitalization days, which does matter in terms of demographics now when even leave sometimes become difficult. So, of course, they went ahead to say that RFA should be considered first line treatment for benign thyroid nodules. I think that would be a large conclusion for a single paper. That should be still be multidisciplinary team decision. And I think the endocrinologist, the surgical oncologist, the endocrine surgeon, and everyone can sit together and plan that what should be the first line. So, and the experience kept on evolving. 2009, they came out about this option on their website. They came out with indications and efficacy of the procedure. 2012, they first time came out with their guidelines, and 2018, they refined their guidelines after multiple randomized control trials and meta-analysis and conclusions from them. So let's see some consensus statement and recommendations from them. So this don't recommend to do it for each benign nodule or just for patient apprehension. There are fixed indications when we do it. If a patient has a benign nodule and one or more of the following features only, then we will offer this. One is a symptomatic problem, mostly pressure related. Either the patient has breathing difficulty or swallowing difficulty due to the nodule size, which is compressing upon the trachea or the esophagus. Then we can offer this. Second is a cosmetic problem. We have a subjective cosmetic scoring from 1 to 4, where if the patient is actually disturbed because of the cosmesis, especially young patients, then we can offer this treatment as an alternative. And of course, if it's a thyrotoxicosis nodule and a hyperfunctioning nodule leading to thyrotoxicosis, and we have documented that with a nuclear scan, correlating with the ultrasound, we can of course target that and ablate it, and the thyrotoxicosis should immediately get relieved. So, what is the pre-procedure evaluation required before we suggest ablation for benign thyroid nodule or even a recurrent thyroid nodule in the cancer bed? So, one is that we have to have two FNACs distinctly performed, so, and both of them should document that it should be a low Bethesda, completely benign, mostly Bethesda 2. So, if the a single FNAC won't do, of course, there are few exceptions where the nodule is Thyroid 2 or classically benign, a spongiform or a cystic nodule on ultrasound, then even a single FNAC suffices. They have very detailed that in their guidelines. But usually you would, in a solid nodule, Thyroid 2 or 3, you will always go for two FNACs. And then you'll of course keep into mind the ultrasound features of the nodule, the clinical evaluation, the nodule volume. They don't recommend it for smaller nodules because then it would be unethically used. It should be a larger nodule, preferably more than 20 cc, at least more than 14 to 15 cc. Symptom scores and cosmetic scores should be objectively documented. Lab tests are done, and we can have any imaging or nuclear scan depending on the endocrinological advice. So again, like I said, they got refined and updated and published in 2018. And not only Korean guidelines, this same guidelines started being incorporated in rest of the world. Italian opinion statement came out, and Italy accepted RFA for more than 20 ml nodules, even for autonomic functioning nodules, especially when radioiodine was contraindicated or declined. Even for recurrent thyroid cancers, they said we can do it for palliative or sometimes curative purposes. Nice guidelines from UK incorporated RFA for benign thyroid nodules. USA is on the front and has started trials for the same. Uh, just a note, China is also doing a lot of work on microwave ablation, which is just a different device, but same principle of thermally ablating the lesion. So, but how to select what kind of ablation procedure to be used, especially depending on the morphology of the nodule, whether it is a cystic nodule, a predominantly cystic nodule, or a solid nodule, a predominantly solid to solid nodule. We know about them by, again, Dr. Chandralula sir's presentation, so I'll not go into details. So if it's a cystic nodule, let's start with a benign cystic nodule. If it's a cystic nodule, then studies and head-to-head prospective RCTs comment that the therapeutic success rate of both ethanol ablation, absolute alcohol ablation versus RFA is almost the same. We can aspirate it and inject absolute alcohol, or we can aspirate the fluid and then burn the wall with the radio frequency or thermal ablation, and we'll get almost 100% efficacy. Earlier studies had a 95% efficacy as this study, but then latest trials, RCTs, show that almost nearly the therapeutic success rate is 100%. But still, if we have to choose one over the other, then we will go for absolute alcohol ablation, because one, it is very cheap compared to RFA. Second, the number of treatment sessions in these studies were lesser for chemical ablation, because you can just inject the absolute alcohol dose and it nicely ablates the entire wall. RFA, you may miss it due to subjective operator usage. This is another prospective RCT comparing the two. Like I said, recent studies, prospective RCTs, they are showing 100% therapeutic success rate in both the arms. and actually zero major complication rate. So volume reduction was also equal. In fact, both of these arms showed treatment in a single session, but again, ethanol being cheaper for a cystic nodule, we would, giving that cost benefit, we will always recommend a absolute alcohol ablation versus a RFI. So because of fewer treatment sessions and cost effectiveness for cystic nodules, we are very clear we'll go for absolute alcohol ablation, although RFI is equally effective and with no other complications. Vis-a-vis now coming to a predominantly cystic nodule where the cystic component is definitely more than 50%, but there is about 10 to 40% of solid component in the lesion. So what do you do in those instances? Even in those instances, although RFA does have a slight more advantage of therapeutic success over a ethanol ablation, it's not statistically significant. So both of them are almost equally efficacious, and the complication rate is near 0 to 1%. So again, giving the cost effectiveness on ethanol, we can still go for ethanol. That being said, what about those patients in whom the solid residual nodule still causes symptoms, even though statistically non-significant? That may still be an issue. Ultimately, the patient wants relief, even if he is that one patient who does not get complete relief. So then this paper came out which said instead of head-to-head comparison on what is the first-line therapy, why not use ethanol for all patients, and those patients who still have residual disease, use RFA in them. For example, this paper again from Korea, they used in the World Journal of Surgery, they used ethanol ablation in 137 patients. And I'll just take a pointer also. Yeah. Yeah. So they used ethanol in 137 patients, and 27 of those patients had some residual disease, which was still leading to mild clinical problems, although lesser than before, but the clinical or cosmetic scores or pressure scores were still there. So they used RFA for those 27 patients, and that achieved 100% result. And the nodules were completely ablated over a period of time, completely disappeared. So this is one example from that study where they aspirated all the cyst. We can see this is a predominantly cystic nodule. The solid component is hardly 20 to 30% of the nodule. So whatever remained was only the solid component. They injected ethanol in that. On follow-up, in a contrast-enhanced ultrasound, Dr. Chandra sir mentioned it in his presentation, they could see that lot of a nodule was hypoechoic and almost dead. This is, sorry, a color Doppler image, but there was some live tissue which had intranodal enhancement. So they repeated a RFA for these residual disease patients, and then complete nodule shows complete burnout, ablation, and complete necrosis. That's why it's turned hypoechoic, dead, and no Doppler pickup. And finally, we know this will shrink and disappear eventually. So when it comes to predominantly cystic nodule, rather than one versus the other, what we can do is use chemical ablation at the forefront. And if there is any residual disease, we can do a RF on a later date. In fact, if we use a contrast enhanced ultrasound on table after the chemical ablation and we do see significant solid tissue, we can immediately use a RFA in the same setting. No need to call the patient back. So very clear in that regard that a combination therapy is best with chemical ablation first and RFA as a bailout. But when it comes to solid nodules, predominantly solid nodules, more than 50% solid area, or completely solid nodules, almost 90 to 100% solid area, then chemical ablation or ethanol ablation completely fails. As we see in this table, as we are going towards the solidity is increasing, the success rate of or efficacy rate of ethanol or chemical ablation starts going down, whereas RF ablation still holds a very good ground in these nodules. Again, these statistics are old statistics, they only keep on improving and reaching near 100%. So when it comes to solid nodules, there is no doubt, as an interventional radiologist, I wouldn't even attempt ethanol ablation, would probably straight go for RFA or microwave ablation, which I more commonly use than RFA because it does not have limitations of heat sink. So any thermal ablation modality can be used. uh, Traditionally, many endocrinologists know that laser ablation was being used for these kind of procedures, but after advent of RFA and microwave, it has been found that even a single session of RFA is more efficacious than 3 sessions of laser. So beyond doubt, multiple meta-analysis, thermal ablation in form of RFA or microwave is way better than laser. So our conclusion based on the morphology of the nodule and based on the solid component, for cystic nodules, ethanol ablation is the best. For mixed nodules, predominantly cystic nodules with 10 to 40% solid area, a combination is best. We can use ethanol ablation. And if there is residual solid nodule, we can use RFA or any thermal ablation modality like microwave. And for solid nodules, we use RFA or microwave. So I'll just complete with a short message on how we do it, so that we understand. So for a RFA, we use generators, about 200-watt generators, which are connected to electrodes, short electrodes, easily very user-friendly electrodes. And we generally go from the midline via a transisthemic approach towards the nodule. For example, in this presentation, we can see I puncture it from the midline. I go through a lot of thyroid parenchyma into the nodule. I just burn a 1 centimeter diameter zone and just switch on the electrode, the machine, and the electrode tip heats that area about a 1 centimeter diameter. I start retracting it back, burn another area. Again, this is called the moving shot technique, the third area, and so on. Then I can go to the fourth area and then I can cover the entire nodule. This is a single slice, and then I can keep on going cranial and cover the entire nodule this way. Just a word of caution, there is a danger triangle where the recurrent laryngeal nerve lies close to the tracheoesophageal groove, and that's why I may not thermally ablate this component of the nodule, and I'm happy to leave 1 to 2% of the nodule rather than trying to ablate and get a full success but endangering damage of the recurrent laryngeal nerve. Because of this, just leaving about 2% of the nodules, we are able to save the nerve in all of the patients, and the chances of injury or permanent damage to the nerve are almost negligible.
Dr.
So,
Gaurav, last 2 minutes.
sure, sir. So this is just the slide showing a thin needle, putting a local anesthetic and hydrodissection around the nodule. This is the ablation needle, which has started ablation and moving shot technique. Here the needle is being retracted and it is being ablated at multiple instances. Completing my presentation on the role in malignancy. If there is recurrent malignancy in the tumor bed after operation, and we see that there are few deposits or lymph nodes which have come back, and those deposits are oligometastatic, just 3 to 4 of them in the tumor bed and nothing beyond the neck, no metastasis, then we can even think of ablating those mets or those deposits, and that can give a palliation or sometimes even complete cure to such mets. These are the number of studies, and I'll just quickly show how much can we expect a complete disappearance of these meds. So if we see latest studies 2014 to 15 are showing as good as 82 to 86 to 94% complete disappearance of all metastasis. Even if recurrence occurs out of 34 tumors in 32 patients, only one patient has a recurrence. Out of 61 tumors, only 4 tumors or deposits recurred after a certain period of time, and so on. So again, few people who have palliatively targeted to do it, even they have achieved very good palliative results. So I won't take the video and how the procedure is done. This is the local latest patients amongst the 12 patients as a cumulative experience of mine. But this patient was done in Bhaktivedanta since I've joined from a year. And this patient presented with a 26 cc nodule, which we ablated because the patient did not want to go for surgery, had a lot of pressure symptoms and cosmetic score, was not happy with the cosmesis, young female. So we ablated the nodule, and finally we, at 2 months follow-up, the nodule has shrank to 4 cc size. And by 1 year, I expect it to almost disappear. So I thank everyone, and especially the organizers, for this opportunity. And in view of time, the chairpersons can decide if we want to take questions or at the end.